Members, we're going to formally open the meeting. You're all welcome. Just to inform members, all electronic devices, with the exception of the committee tablet devices, must be switched off completely whilst the committee is in session, because they are interfering with the transmission and the recording of proceedings. So I'm asking people to ensure that their tablets are switched on to mute mode to ensure that the quality of sound recording is okay. Also, just want to draw attention in relation to this to a decision made by the Chairperson's Liaison Group at the meeting on Tuesday the 16th of February. The decision is about a pilot programme on the use of electronic devices in committee meetings by journalists and the public. Members will be aware that the rules prohibit the use of electronic mobile devices in committee rooms by both the public and the media. The Chairperson's Liaison Group was informed of a recent review of these rules, which included consideration of the approach taken in other legislatures, and as a result of that, it has been agreed that there will be a pilot that will run until the end of the mandate. The pilot will assess the viability of allowing the media and the public to use their electronic devices in the public gallery. Some conditions will obviously be applied, namely that devices will be on airplane mode, not 3 or 4G, and that no recordings or photographs will be taken. It's not anticipated that there will be any problems with this. However, should members or indeed staff notice that it's been used to record or take photographs, they should bring it to my attention, and I will ask for it to stop. So those in the public gallery are welcome to use their mobile devices as long as they are in airplane mode and that all devices are muted. You're obviously welcome to connect to the Assembly Wi-Fi, and password details are obviously unavailable or are available as the rules apply. It's not permitted then to take any photographs or record any of the meetings. So that's for members' information. It is a pilot that will run until the end of the mandate. So next item then is apologies. Do members have any apologies? I know Fergal McKinney sent apologies. Any other apologies? No. Okay, members. Item 2. There's a number of items under Chair's business. I just firstly want to refer to the Commissioning Plan Direction, which sets the priorities obviously for 2016-17. Just to remind members that we still haven't had sight of the Commissioning Plan as of yet. Last year we got a draft early in the year. So again, members, I'm seeking agreement that we write back to the Department requesting a copy of the direction for next week's meeting, as it's not going to be made available to us. If it's not going to be made available, what are the reasons for that? And also just want to raise 2 other items under Chair's business. The issue of perinatal mental health. There has been a piece of work done through the Public Health Agency. There are obviously quite stark figures in relation to 80% of trust areas that have no access to specialist care, and the 20% of women who are affected by perinatal mental health issues. So I am seeking agreement that we would write to the Department to get an update as to how that strategy or piece of work will be taken forward. Members in agreement that we would do that?
Yes, Chair, I was in that all-party group and it was very alarming that there was so little support there, so totally agree.
Thank you for that. And thirdly, under Chair's business, just seeking agreement that we would get an update from the Minister and the Department in relation to the 1% pay increase for nurses as to where that is currently situated. So thank you.
Absolutely, yeah.
Thank you for that. Okay, members, item 3 is the draft minutes of the meeting from Wednesday the 10th of February. Just referring members to the meeting pack. The minutes are on page 6 of your meeting pack. So are members content with the minutes? Yep. Okay, members, item 4 then is the Health Miscellaneous Provisions Bill, the further consideration stage. Seeking agreement to add the Health Miscellaneous Provision Bill further consideration stage to the agenda as item number 14 and to deal with it at that stage. just to inform members that the Minister has written providing a copy of the amendments that he's tabled for further consideration stage, which is scheduled for Monday the 7th of March. The correspondence and the amendments can be found in your tabled pack, and copies of the bill as amended at consideration stage are on your tables. So there are 14 amendments in total. 12 relate to nicotine products and tobacco, the levy on sugar-sweetened drinks and human transplantation. The remaining 2 are consequential amendments to the long title. So at this point, members, I'm going to seek your views. If you have any at this stage on the amendments relating to firstly nicotine products and tobacco. Do members have any comments at this stage? No. Okay, no other comments at this stage. I suppose just from my own point of view, I think just it would have been useful, I suppose, to get clarity from the officials, and maybe they can clarify that. But specifically noting that within the amendments we talk in relation to the removal of vehicles in some parts of the amendments and other places being inserted, I'm just, I suppose, querying the rationale for that wording, and maybe we could seek that update from the department in writing, maybe in advance of Monday's debate. Secondly, the amendment on the levy on sugar-sweetened drinks. Again, members, my only thoughts on this is that we are talking in terms of changing the time from a year to 2 years. And again, I would seek an explanation for that, because the original amendment was very specific, talking in terms of the consultation to be conducted a year after the commencement of the Act. So I'm not sure what the 2-year time frame is. And again, I would just raise that as potential, looking for clarification on it. Any other comments in relation to that proposed amendment? The third one then is in relation to human transplantation. Any thoughts at this stage? Okay, well, at this point, I mean, we can either decide to support the departmental amendments or simply note at this point. And I think from what I'm hearing, members are content to note.
Well, I was going to support, but what's the difference?
Well, I think there's a number of clarifications that I would certainly to just have clarified. And I think for the purposes of this, because I'm just mindful that members are only starting to work their way through these amendments as well, and there obviously is the space when they come to the floor of the Assembly. So if members are content to note at this point, that's completely appropriate as well. Thank you. Okay, members, moving on to item 5, which is a departmental briefing excuse me, on the Protect Life strategy. Just to advise members that departmental officials are here to brief the committee today on the strategy, and just want to refer members to the briefing paper at page 11 of your meeting pack. Okay, you're both very welcome. We have Gerard Collins, Health Improvement Policy Branch at the Department, and Mary Black, Assistant Director of Public Health at the Public Health Agency. So I'm going to invite yourselves to make the presentation.
I lead on that then, sure. So good afternoon, and thank you for inviting us here to provide an update on suicide prevention. I'll start off just by briefly mentioning you've already received the paper that we provided that covers a lot about the suicide rates in Northern Ireland, so I won't go into any significant detail on that at this stage. But I would like to highlight that the suicide rate here remains high at slightly over 16 deaths per 100,000 of population. This equates to 280 deaths per year on average over about the last 5 to 6 years. The Northern Ireland suicide rate is the highest in the UK. Comparable rates are, and it's difficult to get exact comparisons because of the recording methods, but around about 11 deaths per 100,000 in England, just under 16 deaths per 100,000 in Wales, and between 14 and 15 deaths per 100,000 in Scotland. Scotland has been experiencing a steady decline in its suicide rates over the last number of years, a slow decline but a steady one. The rate in the Republic of Ireland is 11 deaths per 100,000, although if you include deaths by undetermined intent, this goes up to 13. Broadly speaking, we have for a while had the highest suicide rates in the UK and higher than the comparable rates in the Republic of Ireland. So in view of this, the Department allocates over £7 million annually to suicide prevention here. This is more per head of population than in any other UK country, and this figure does not include significant contributions from mental health services and from other Northern Ireland government departments. In addition, local charities, the community sector and some businesses contribute funding and resources to suicide prevention, and it's a welcome development that one or two businesses are starting to actually allocate staff within their businesses to suicide prevention and to work within the community sector and school sector on suicide prevention training. It is also important to highlight that the burden of suicide is not equitable and remains higher in certain areas and among certain groups. As is the case in many other developed countries, 3 times as many men than women die by suicide in Northern Ireland, and the suicide rate in the most deprived areas is 3 times higher than that in the least deprived areas. The rate of hospital admissions due to self-harm is 4 times higher in the most deprived areas than in the least deprived areas. Young and middle-aged males in deprived areas are particularly at risk, as are other marginalised groups such as unemployed people, people with mental illness, ethnic minorities and people with addiction problems. Of particular concern is the early indication that there has been a rise in suicide levels in 2015. The recent provisional statistics contained within the Registrar General's quarterly report show 246 recorded deaths in the first 9 months of 2015, compared with a total of 268 deaths for the whole of 2014. Moving on then to some progress on actions on suicide prevention. As you probably know, there's a wide range of suicide prevention services in place to help identify and support people who are in severe emotional distress. These include bereavement support, the Lifeline Crisis Helpline, community-based counselling, access to psychological therapies, suicide awareness and intervention training, addiction services, self-harm prevention services and public information campaigns. Significant new developments over the past year include consultation on a new model for the Lifeline service. The Minister is currently considering the Public Health Agency consultation report on the proposed future model and options for commissioning and delivery of Lifeline. There's been some substantial comment on the future of Lifeline. Some of this has actually been around concerns that Lifeline is coming to an end and won't be replaced. That is not the case. The Lifeline service is to continue, but possibly in a different format and different shape. There has been production of annual reports in the Self-Harm Registry, which is fully operational now in all emergency departments. These reports help to inform policy and service delivery. Allied to this is the rollout by the Public Health Agency of the Self-Harm Intervention Programme, which is delivered through voluntary organisations and is in place across all 5 trust areas. Furthermore, the PSNI is working with the health sector to continue to refine and develop the sudden death notification system, which provides virtually real-time information on suspected deaths by suicide. This information helps identify potential emerging clusters of suicide and ensures prompt support for bereaved families. Plans are in place with the PSNI and the University of Ulster to develop specific training for officers on the sudden death notification system. It is also worth noting that other jurisdictions have expressed an interest in establishing a similar notification system within their countries. An important initiative has been the Churches Initiative Flourish. The 4 larger Christian churches are participating in clergy training on suicide prevention under this initiative. This programme helps churches to address the needs of church members and parishioners affected by suicide, and the programme is being rolled out across Ireland as part of the All-Ireland work on suicide prevention. There's also 2 major pieces of local research that have recently been completed and will be published next week. Both have examined records relating to a large number of suicides and have drawn out issues around the circumstances of these deaths. Issues identified have included the impact of the Troubles, deprivation, relationship breakdown, importance of primary care settings for suicide prevention, and the need to target people who have had difficult life experiences. The research will contribute to our understanding of prior suicidal indicators and the identification of measures that can be taken to prevent deaths by suicide. The Ministerial Coordination Group on Suicide Prevention met on Monday, the 29th of February, just past, and a very substantial range of work going on across departments that contributes to suicide prevention and mental health promotion was highlighted. Some of the significant pieces of work were the Department of Education I Matter programme, which is promoting resilience, emotional resilience in pupils. And the Department of Education have also been working with the Department of Health on developing the Protecting Life in Schools framework to safeguard emotional health and wellbeing of pupils. The Department for Culture, Arts and Leisure have undertaken mental health and wellbeing training through sport and have been engaging with many of the sports governing bodies to ensure training for sports coaches. And work continues with the Prison Service and PSNI to further develop staff training programmes on suicide prevention and the development of safer custody settings. Moving on then to the new Protect Life strategy. A draft of the strategy is in an advanced stage of development. There has been comprehensive pre-consultation engagement with stakeholders, and that feedback has helped to further refine the current draft of the strategy. The intended focus of the new strategy will be on frontline intervention for people who are in emotional distress and on postvention for meeting the needs of families and friends who have been bereaved through suicide. We are working to finalise the document and will shortly request the PHA to develop an implementation plan before going through the formal approvals process within the department. In terms of, we often say that to reduce suicide in the long term, it's necessary to go upstream and promote emotional resilience. The intention at this stage is that mental health promotion will be addressed under a separate and new action plan that will be developed under the umbrella of the Making Life Better public health strategic framework. This will focus on tackling some of the wider risk factors for suicide and developing stronger emotional resilience in population groups that face greater risk of suicide, either currently or in later life. Much of what other departments reported in the ministerial group will actually fit within that action plan, and that therefore includes my update on progress to date.
Okay,
thank you for your attention.
Chair. Thank you. What have been the lessons from the original Protect Life strategy?
In terms of the consultation feedback and the independent evaluation of the initial strategy, the lessons are that we need fewer actions. There were 62 actions in the strategy, and it was felt that that, to an extent, dissipated activity across a very wide area. So the evaluation recommended that we focus our actions and theme them and group them so there's more direct focus on particular areas such as training, for example, such as awareness raising. It also recommended an enhanced focus on the primary care setting for suicide prevention and better coordination of activity among groups delivering suicide prevention services and between the statutory sector and the voluntary sector. The feedback from pre-consultation engagement has largely been that most of what we already do in terms of suicide prevention, stakeholders want to see retained. So, for example, stakeholders want to see Lifeline retained, want to see awareness raising. There have been some calls for more direct public information campaigns around suicide. I know the PHA have concerns about being more direct about suicide. In terms of community support, there's a strong need and a strong emphasis on retaining the commissioning of suicide prevention services from the community and voluntary sector. Other things that we've learned is that another very important setting for intervening in suicide prevention is police and custody settings. The PSNI recently noted that very large numbers of people who come through custody are at risk of self-harming. One of the things that we know in terms of suicide prevention is that contact with the justice system is a risk factor for suicide and self-harm. We also are aware that somewhere between 28 and 30% of people who die by suicide are not known to mental health services. So the need to capture that 70% of people who die by suicide who haven't been using mental health services is an important priority. And the two settings, the two most important settings for that are probably primary care services and police and prison services, with community sector services coming in a bit third on that.
But I suppose, would you not agree that when we look at the figures, because it's a human tragedy, every single one of those cases, but when we look at the 268 deaths in 2014 and 246 deaths in the first 9 months of 2015, 20% higher than the period of the previous year, that there's something fundamentally failing. We can't honestly say that Protect Life strategy has worked.
I would answer that by saying we can't say either that it hasn't worked, because some time ago, as the Northern Ireland Audit Office pointed out, it's virtually impossible to assess the impact of a single strategy on such a complex issue as suicide, because we know what drives suicide is a lot of the wider social determinants such as unemployment, poor education, deprivation, addiction, in some cases dysfunctional family circumstances. And we've said this time and again, that to address suicide in the long term, there needs to be a coordinated effort to address those wider risk factors for suicide. And until we make progress in those areas, particularly in relation to deprived areas, and improve the social circumstances and the economic circumstances of people living in those areas, we will continue to be firefighting in terms of dealing with people who come to services who are suicidal, or who come to community services who are suicidal. And I think we've got to the sort of pitch where we are in dealing with, we're quite good at crisis stabilisation when an individual comes forward to services. I think we need to look upstream further, as I said, addressing the social determinants, and we also maybe need to, what we haven't to the same extent to Protect Life, is to look at longer term recovery from people who are self-harming and who are suicidal. So whilst we're good at stabilising the situation, and work does go on in terms of longer term intervention, I think we need to highlight that at a strategic level, and that's something we intend to do in the new strategy. But in terms of saying the strategy has failed, we look around internationally. What we do here is what other countries do. What we do here is what the evidence shows what works. Now, the evidence around what works in suicide prevention is not substantial, and there's only, in terms of really properly peer-reviewed evidence, about 3 or 4 things that are known to be effective. One of those being restriction of access to means, which is something we do here, and access to mental health services, and sensitive media reporting. So we're doing what we know, what the international evidence has shown us that we need to do. We're doing what other countries do. Our Protect Life strategy has been very similar to the Choose Life strategy in Scotland. Scotland has achieved, as I said, that steady reduction in suicide rates. There is very little we do that's different. I know that in Scotland they put a lot of their success down to their awareness-raising campaigns and the fact that they have had a huge focus on training and suicide prevention in NHS staff and in community gatekeepers. Again, we have that focus here. We maybe haven't reached the same level of coverage in training. That will continue to be a focus, and that will be in the new strategy. But we're yet to find an intervention that has worked somewhere else that we haven't employed here. I mean, the alternative is we either stop doing what we do, or we stop doing it and do something else, but we haven't yet identified what else that can be, or we do more of what we do here, and to do more of what we do here would probably require further resources.
But why? How is it taking so long?
Sorry, Chair, what's taking so long?
From the final stage of the Protect Life strategy to this revised Protect Life strategy? I mean, this committee was told by Michael McBride in 2012, and I quote, "The independent evaluation of the Protect Life strategy was commissioned in 2011 and is nearing completion. The new strategy will be taken forward from 2014, and we hope to go out to public consultation on that in 2013. The findings to date will be published in full in September." That was 2012. Why has it taken us 5 years?
Well, we refreshed the Protect Life strategy to run from 2012 up to 2014, so it's not correct to say it's taken 5 years. We produced a new document for those 2 years. That document remains current. We had hoped to have the new strategy in place last year. There have been resource constraints. There's also been a very, very high level of interest in suicide prevention, which means a very high level of support work within the department for dealing with correspondence, for dealing with participation on various groups. And as resources directed into that, it has left less time to devote resource to developing the strategy. What we intend to do, and what the Population Health Directorate intends to do, is to restructure some of the reporting lines in terms of the day-to-day support work on suicide prevention and carve out time to devote resource to the finalisation of the draft.
Again, and bear with me on this as well, and I'm sure people directly impacted in this particular issue will not understand an explanation that there was resource implications as to why we couldn't get a new strategy in place, whether it's 5 years or 2 years.
That's the reality of the situation.
What
we're a small team.
What resources?
Staff resources.
Surely staff resources. So
Yes.
we're saying now we didn't have staff resources in place.
No, what I'm saying is the workload in terms of the day-to-day workload that the department carries out in terms of suicide prevention has increased. By the very nature of the fact that that's an increase, that has consumed further staff resources. That work tends to be reactive. It can't be planned. It's demand-led, and it tends to be very short deadline work. So we have to devote resources to progressing that.
So maybe another way of answering this: how high priority is this given?
I think with the very fact that suicide prevention has allocated $7 million from the department, and that funding over a number of years has been ring-fenced, shows that a high priority is given in terms of resource allocation to the implementation of Protect Life.
But you will appreciate, and I know that you've heard this directly yourself, but I suppose groups and services delivering and trying to tackle this at a very core root cause, would question why they have been attempting to do this in the absence of an overall strategy from the department?
Well, the current strategy still, the 2012 to 2014 strategy, that's what PHA continue to work to. And in terms, I mean, as I've said, in terms of the feedback from consultation, a lot of what we currently do is what stakeholders want to see retained. So those services are likely to be retained within the new strategy. So PHA works, PHA develops its annual suicide prevention, mental health promotion thematic action plan. It procures services against that. So there is no ceasing of services or no ceasing of the commissioning of services. That continues to happen.
But there's just, it's been the absence of leadership, I suppose, the absence of strategy. Because, you know, I do go back to these comments, and I don't call into question Mr McBride's evidence to the committee, very specifically indicating to us that the evaluation of the strategy was commissioned in 2011 and was nearing completion. So there has been a huge gap there. And whilst I accept this hasn't been about the absence of services, it has been in the absence of a strategy.
The evaluation of the strategy in 2011 fed into the update to the suicide prevention strategy from 2012 to 14. So that strategy took account of what the evaluation said. And you will see, if you look at the original Protect Life strategy and the refresh strategy, that there are key differences in terms of the strategic actions.
So 2014 on?
2014 on, as I said, it's regrettable we didn't get the strategy produced and published in 2015. We're still working to it. We went through additional pre-consultation engagement to ensure that stakeholders were involved in the development of the new strategy. That has been time-consuming in its own right. Responding to that has been time-consuming. But that we want to get the document right. We want to have buy-in to the document. We want we want stakeholders to feel a sense of ownership of the document. So that has all taken time to get there.
So the key issue in that delay between 14 and 16 has been resources.
Resources and an increased workload in terms of the general level of political and public interest in suicide prevention and the need to respond to that level of interest.
And the key lessons that we would expect to see coming out of this new strategy would be fewer actions and enhanced focus on primary care?
Well, there's more than that. What we're identifying then in terms of what will be different is the focus on primary care, the focus on custody settings. One of the big issues that has come up is the data on suicide. We have various databases on self-harm and suicide. So I think we need to start look at how we can mine those databases in a more effective way to produce information that gives us further evidence on what is driving suicide, what are the local risk factors for suicide, so the focus on data and better analysis of the data will be part of the new strategy as well.
And when are we likely to see that strategy?
We hope to have the strategy approved by Minister towards the end of this month and out for public consultation around June.
Okay, and just let me deal with the issue in your paper around self-harm. And there was 8,453 presentations of self-harm between April 2013 and March 2014.
Yes.
Indicating there was almost 6,000 people involved. Some of those cases were repeat. And then there was an additional 3,623 cases presented with suicidal ideation. In terms of those 9,600 plus people, how many received, and you may not have this information, but how many would have received a psychiatric assessment before leaving A&E?
A full psychiatric assessment? I'm not aware of the exact figures. We'd have to come back to you on that if we even can produce those figures. In terms when someone arrives at A&E in emotional distress or having self-harmed, there is an assessment carried out. A suicide risk assessment is carried out. If that risk assessment is low, the person is offered an appointment with community psychiatric services through the Card Before You Leave system. If the risk is assessed as high or medium, generally then a full psychiatric assessment is carried out and the individual is admitted to inpatient facilities in a lot of those cases.
Would you, maybe, and I'm probing on this a bit, suggest or agree that there are, I'm using my words carefully, better ways of fulfilling requirements around psychiatric assessment processes? There is anecdotal information, I'm sure most or all members get it, about individuals who turn up at risk and who leave A&E departments before a proper psychiatric assessment can take place, and unfortunately end up back there after a period of time. Do you have a view to that assessment process in our emergency departments? Is it robust enough? Is it effective enough?
Well, I think, given the circumstances, and we all know that A&E departments are not a great place for a person who's in emotional distress to be, that the likelihood is that a lot of people will leave before the assessment. It's important that those people are followed up, but it's in terms of waiting times, I couldn't say what the waiting times are for assessment, but I know that trusts have been working to reduce those waiting times with a specific focus on suicidal patients at A&E. And I also know that there's been a programme of training on suicide prevention for A&E staff so that they are aware of the priority of intervening with patients who are suicidal. And that's a Cascade Training for Trainers programme, part of the broader suicide prevention training process. But in terms of the robustness of the assessment, I wouldn't be able to say at this stage. But
I'd be very interested in getting those details in terms of those figures that you've given us, the 9,623 cases. What psychiatric assessment took place, and were all these people given a card before you leave? Were they followed up?
There was an evaluation some years ago of the Card Before You Leave system, and by and large it showed it was working quite well. I think there was one or two, there's a few instances where people won't receive the card. I know that in some of the A&E departments they were favouring a follow-up by telephone and found that to be more effective. And one of the problems with the Card Before You Leave process was the very large number of appointments that weren't attended. But that seemed to come with the territory.
Okay, well, can you come back to us specifically on that detail that I've asked? Finally, for me, you talked about other interventions, and I know you attended the all-party group on suicide prevention during the week. The zero suicide model in terms of healthcare. Would the department have a view to that?
We have made reference to it within the new draft of the Protect Life strategy and a commitment to considering how, to investigating the approach and identifying how it can be adapted for implementation in Northern Ireland. So in terms of the outworking of that, we would see that as being along the lines where we would set up under the strategy a working group to look, a task and finish group, to look at how Suicide Down to Zero has been implemented elsewhere, particularly, as you know, in the Mersey Mental Health Trust. What we can learn from that, there will be differences to our structures here, of course, but in terms of what we can apply here, and if we will need to do a business case If the business case is successful, I would envisage a pilot exercise within mental health services in some part of the health sector that would actually trial that approach, and then that would have to be evaluated after a number of years. But there would be a cost for that, so we would have to.
And is
come up
that
with a
now,
business case.
did you indicate that that was included in the new Protect Life strategy going forward?
It had been in the strategy before the event.
Can I welcome that? I mean, I don't think it's a panacea to all of our issues here, but it's certainly more than a concept, and I suppose how we shift it onto a set of practices, particularly within health. I would be very keen to.
Yeah, I think we can learn from Merseyside, the Mersey Trust, where they are starting to shift from the concept and the idea of the approach into a practical application of the approach.
Okay, thank you for that. Now I have a number of members. Joanne first.
Thank you, Chair. Can I thank you for your briefing? Firstly, given your projected increase in rates for 2015, which we'll know in April, isn't that correct?
Yes.
Are you concerned that, you say in your briefing, the development of the Protect Life strategy has been slower than anticipated? And given the questions and the answers to the Chair, I think that's certainly an understatement. So ideally, where would you have liked to have been at this stage? Because you've cited increased workload among other factors that have hampered. Where ideally should you have been, would you have liked to have been at this stage with it?
Oh, I mean, well, clearly we would like to have had this strategy out last year, and our colleagues in the Public Health Agency working on an implementation plan then for the strategy.
I was just wondering if I could make a general comment about that, because less about the strategy and more about the actions that we believe are effective actions. Because even in the absence of the strategy per se, people have maintained very important actions that we know will be supportive in terms of suicide prevention. We also know from the international evidence and our own local evidence that we have to do this at scale and over time before we will see a reduction in deaths from suicide. As you say, every single death is a personal tragedy as well as a cost to us as a society. But we do know, and I actually, in preparation for this meeting, had a look back at Dr. Annette Beautre's outline in terms of what is effective in terms of suicide prevention. You may remember she's a world expert, came over from New Zealand a couple of years ago. And one of the things that she says is absolutely paramount is the population approach. That if you only focus on those groups that are deemed to be at risk, you miss the point. That yes, you have to provide special services and support for those individuals and their families, but we have to have a whole population approach, and that will require investment over time across all of those issues, including public health information. So whilst the deaths are looking as if they're going to be an increase this year, it is not true to say that we haven't had progress in many other areas, including the self-harm registry, the services in place, a reduction in stigma, and a greater willingness to come forward for services. But every single one of those gains, of course, forces you back to, and what else do we need to do? And I think that's the place we are now. It's not that the actions we've taken are not effective. I think we have some confidence about that. Plus we have an independent evaluation and we're stacking it against international evidence. But every single one of us has to ask that question, and what else do we need to do, and reflect on our learning to date. So, and part of that is building the effective actions over time and at a scale where we will see impact. And I would just finally just make a connection with other strategies that are equally important. The drugs and alcohol strategy. We know alcohol, the minimum unit pricing of alcohol, all of these issues are related. Secondly, we know that within the agency and with the Trust, we're placing a great deal of emphasis on early years intervention, because building that resilience from very early on will help. But we have to do these over time and at a scale and consistently interrogate the problem, because it is complex. So it's just by way of comment on the actions that are in play, whilst we still have to look at the future and what else do we need to do.
Gerard, you referred very briefly to the community and voluntary sector. I'd be interested to find out what links does the department maintain with charities and organisations. I'm thinking just off the top of my head, Yellow Ribbon, Mindwise, PIPS, Action Mental Health Links. There's so many fantastic charities and voluntary groups doing amazing work out there, and without them, where would we be without them? So what links are you maintaining then to ensure that this all-important ear to the ground approach when it comes to support comes from us for suicide prevention? Can you outline that?
The governance structure for Protect Life has the links built into it with the community and voluntary sector. So, for example, we have the Suicide Strategy Implementation Body, which advises the department on the direction in terms of the implementation of the strategy, which feeds back intelligence from ground level, and which on occasion can and does challenge the department in terms of the focus of delivery. There are around 40 members of the Suicide Strategy Implementation Body. It meets quarterly. At least half, if not more, of the membership is made up of representatives from community bodies and charities with an interest in suicide prevention. Then linked to that at trust level, and in some cases in the Belfast Trust there's more than one group, we have local Protect Life implementation groups which engage with the community groups in each trust area who have an interest in suicide prevention. And the statutory services in those areas also run the local Protect Life implementation groups. In Belfast we have 3 or 4 of those groups for the different areas of Belfast, and again they meet on a quarterly basis. And then we have a number of the subgroups for the implementation of the strategy. So we have the Lifeline Regional Steering Group, we have the Bamford Protect Life Implementation Group, and the charities and the voluntaries are represented on those groups as well. So there's a number of subgroups as well as the main groups.
Engaging is one thing, but obviously they're the ones in our communities as well. So listening and acting on, I think, is very, very important.
Oh, well, I can assure you those groups are very focal on those different fora, and we have taken direction and action on what the community groups have said on many occasions. One of the most important groups we have is the Family Voices Forum, which represents bereaved family members. It is by no means the only group that represents bereaved family members, but again the Family Voices Forum is represented in those groups, and indeed produces as a standing item in terms of its progress and its feedback on the implementation of Protect Life at each Suicide Strategy Implementation Group meeting.
Okay, finally then, we all know the very real financial problems our farming communities brought on by a culmination of very many factors. But unlike large businesses, the farmhouse table is the boardroom table, and the issues affect, if a farmer's mental health problems or issue regarding it, affects everyone in the family. And I know in my own constituency we've seen a number of attempted and some cases sadly acted upon suicides among our rural communities. What, as we look to the new strategy, has the department done specifically to include measures around farm mental health to protect those, the rural lives?
Probably Mary would come in here, maybe, but there is the MARA project that the PHA have been working on, the health screening checks at farmers' markets. And I know that the Department of Agriculture and Rural Development have been a very keen partnership on that.
Has been a superb project. Is there anything else
So
given
maybe
the
Mary
areas?
give us the details.
Certainly. Yeah, we've mentioned MARA, which is a partnership with the Department of Agriculture and Rural Development, identifying vulnerable rural households and doing a whole range of checks and then linking people into services and supports. So that's one issue. I think on the broader issue of Protect Life and the engagement with the community and voluntary sector, we work through a number of network organisations, particularly in the rural community. So the rural community networks are a vehicle through which we work in partnership to engage with those rural communities. And that's been very effective, both in terms of the small grants programme, very small amounts of money out to very small communities to do training, education, awareness raising, and various kinds of support, as well as that, and the Farm Family Check Scheme, which is specifically identifying farmers and their families. highly effective, coming forward at, in situations and venues which are more acceptable to the farming community, the farmers' marts and so on, and referring on both to general practitioner and other services and supports. And mental health has been identified in a very high proportion of those referrals.
So you're aware of the increase then as well? And
I wouldn't say we're aware of the increase so much as we are now aware and engaging. I'm not sure you could say it's an increase. We've
some
also
of the
supported.
local charities and
Aye.
pick up are telling me of an increase.
Yes,
but in Yellow Ribbon specifically are dealing with a large increase in
I
farmers.
agree with you, but I think we also have an increase in urban communities as well. I think what's happening and what is positive about the rural community issue is that people feel now more able to come forward and talk about it, even though we still know we have an issue on stigma. The final thing I would say in the rural communities is that we've also supported an organisation called Rural Support, which is directly supporting those parts of the rural
Yes,
community.
I'm well aware, I'm a member of the farming community myself.
Okay.
It's just, given the great need, and I'm hearing of
Yeah.
a massive increase, and the fact that we just passed a rural needs bill placing a duty
Yeah.
on departments and government bodies to consult and consider rural specific issues, I wanted to find out what there was in this strategy
Yeah.
going forward, given the increase.
Well, I think rural communities, as a number of other communities, are in some ways more vulnerable. So they will definitely be and remain a focus for attention, definitely.
But no additional measures other than what
Well, I mean, we will look at that because I mentioned the two major pieces of research that are to be published next week. One of those, carried out by Professor Jerry Levy of the University of Ulster, is about understanding suicide and help seeking in urban and rural areas and looking at the differences there. And that report will produce a number of recommendations which we can then look at in terms of drafting the new strategies. And I know that some of the initial recommendations and findings are about the need to support families in rural areas where there might still unfortunately be a higher level of stigma around mental health, to support families and equip families to cope with a family member who's in emotional distress or potentially suicidal, issues about access to mental health services for rural dwellers, and about greater use of primary care services. So that report will produce a number of findings which will then feed into and inform the development of the strategy.
sectors, they are reporting a massive increase, so at least it's on your radar that you are acting on that.
Yes.
Thanks, Chair.
Okay, thank you, Joanne. And Michael?
Yeah, thanks, Chair, and thanks, Jerry, for the presentation. This is familiar ground to me, so I'm not going to labour it too much. When I was in the department, as you know, I was frequently asked by colleagues in the Assembly, do more, and we were always looking to do more, and the question was, I was asked, tell me what it is you want me to do. Tell me what it is that we're not doing that you think we should be doing, and we'll do it. And I have to say I didn't get many answers. Is there anything that you think we're not doing right now that you would like to be doing? I know you've mentioned cutting down the number of actions, and I remember many years ago people said we need more actions, now we need maybe not so many actions, and I hear that, but is there anything that you think we should be doing that we're not doing?
A couple of the big things that have come out for me have been the need to support families. I mentioned that in terms of the rural scenario, but and I think this happens, but we need to reflect it at a strategic level more so. It's families very often who care for a family member who is in distress, who is indicating signs of suicidality. So the families are key. I think we could do a bit more to train families up, to make families aware of the signs for suicide, and to help equip families to cope with a family member who's suicidal, to respond in the right way, and to respond where a family member is self-harming. There's a huge demand among families to know if a family finds out that one of their members is self-harmed, there's usually bewilderment and a lack of understanding on where to go for help. So we need to be able to inform families and signpost them to sources of help. I touched on the need to join up the different and make more of the different information databases that we have. We need to further refine and develop the sudden death notification process, because that's our real-time information on what's happening. I think when we see an increase in suicides, I think we need to be able to get the data to understand what's driving that, much quicker. And as you'll know, when there is a suspected cluster of suicides in an area or amongst a group, very often a community response plan that are already in place is activated, bringing in a number of agencies. There's learning from each time those plans are activated and when those plans are stood down. So we could possibly do more of taking a step back and look at instances in rural areas and then in urban areas where community response plans have been put in place, run for a while, and to learn from that then, take together the findings from that to find what was driving the increase, that cluster of suicides in that area, and also what interventions worked to prevent further suicides, because that's what the community response plans are about, to prevent a cluster from growing. So I think there's definitely capacity there to learn more from what we do in a more structured and formal way, and share that information on a more regular basis. One of the things we're also intending to do that hasn't done to date is to look at the serious adverse incident reporting system around suicide and suicide attempts within mental health services. The Donaldson Review mentioned that the deadlines for responding to that can sort of limit the quality of information that comes through, and that sometimes that the learning from those incidents is just retained within the unit that the incident took place in. So we have, through the RQIA, commissioned the Guidelines on Audit Implementation Network to carry out a review of the serious adverse incident reporting system, specifically in terms of suicide and suicide attempts in mental health services, to see if that can be changed in any way to improve both how that's conducted, the quality of the information that comes out, and how that information is shared, and how that learning then goes on to influencing services.
Okay, thank you. Would any of that be resource-based? Are you constrained because of resource?
Some of it would require additional resources, some wouldn't. Some is just a change in the way we do things. So, for example, the serious incident reporting system, if we just change the way, it actually might free up resources if we change our approach to that. So some will require more resources, some just requires a different approach and a different way of looking at things.
The issue around, gender, age, deprivation, drugs and alcohol, and so on, and the steps taken around GP awareness and A&Es and so on, but it's the phrase used, help seeking, and that's the key thing, getting individuals to seek help, and that's the first step, because very often, as you say, individuals who are in trouble are not known to services, and a lot of that's down to community-based delivery. Is there more that we can do? Where do you see it? I must say I welcome very much the Lifeline, preserving that. I think that has been a very important tool for you. But what other steps do you see around help seeking that you would like to put in place to try and when you're talking about mental health and it's the jump from adolescent to adult, and your basis there, it's again you see it's teens and 20s where the big cluster is.
We would like to see, in terms of help seeking, is first of all how we identify that 70% who don't use mental health services but who go on to die by suicide. So I touched on that. The big issue is to focus again on primary care, because somewhere in the region of 50 to 60% of people who die by suicide will have used primary care services in the previous 3 months. The focus on custody and settings, justice settings, and the training that goes on, because we'll only identify that 70% if we know who are the sort of community gatekeepers, as we call them, that those people who are in distress come into contact with in those settings. So it's important that we continue to train those community gatekeepers. So that's training for police officers, training for prison staff, training for primary care, training for A&E, training for community workers, youth workers, and the big approach that DCAL took, for example, in training sports coaches. I think that is a very admirable programme. We need more of that, and we need to keep on a continued focus on that training, so that people in those positions then can identify the signs of suicidality, know how to intervene, and know how to signpost the individual to the appropriate services. And the appropriate services mightn't always be mental health services. They could be community-based services. Depends on what the issue the person is facing. They could be family support services. So it's not always, the mental health services route. So I would see that as a very important approach.
Okay.
I would also add that, when you asked the question, I was thinking of three things. One is, I think we need to reflect on the experience that we have, which is continual, but I think, it's important that we continue to do that so that we retain the focus on exactly what we believe will be the most effective actions. And I know there are discussions in Belfast, for example, at the minute to start that process. The second thing is investment, because everything we've talked about is effective, but clearly if you do more of it and if you do it to scale, it will cost more money. And therefore I think investment is important. And the third thing I would say is that some of those predicators of health and risk of suicide lie outside of health and social care. So let's get round the table and talk about, how we address the issue in some communities where young people don't see a future. Now, we are doing that, and we're doing that certainly at local community level, but have we got a sufficient will to create employment, to create employability opportunities, and bring all of that work together? And we've got great examples of it, but could we grow it to scale? Again, the issue of scale for me is important, rather than single, isolated examples of good practice. The final thing I would say in terms of help-seeking behaviour is just, I think public information is very important. We have evaluated the public information campaigns that we've run, and they've been highly effective. But again, there's a ceiling on the amount of that which we are permitted to do. And equally, we need to follow it up with more modern communications around the use of social media, and getting clever about how we reach those people who are not just vulnerable, but can influence their peers. So I think there's quite a lot we can do around the communications, but I go back to scale and investment and working with others, because there's no simple answer to this.
And the important thing in that answer is also, this is not just a health issue.
Yeah.
This is for all departments, all government, local government as well.
Yeah.
Everybody's got to be part of this circle. We used to have a ministerial team that met, they still
Yes.
meet, and bring all the departments together and do the departments in tangible terms actually support.
Yes, and the interministerial group did meet on Monday of this week, and it is heartening when you see the range of actions across each of those departments. I'm simply talking about doing more of that, I think.
Yep. Okay, thank you.
Okay, Michael, Gary.
Thanks, Chair, and thank you for coming along today. In terms of the 2015 figures, obviously they're not going to be out until the end of this month, but is there any indication at this stage as to how those figures are looking for the final 3 months? Do we know?
We have no indication. We'll not get the final quarter until usually April they come in at. But I mean, if we extrapolate from the first 3 quarters, I think they're not going to look good. As the Chair said, it's a 20% increase it's looking like. We have sudden death notification figures for 2015. They're indicating 191 suspected deaths. Now, you would think that the sudden death figures should be higher because that's suspected suicides. But as it says, that process is still embedding. And we're continuing to refine that process. And maybe not all suspected deaths have been recorded, so we say we continue to refine that process. We will eventually get to a stage where we can look at the recorded suicides and the year they occurred in, and compare that with a sudden death notification for that same year, and we'll then see the discrepancy if there is one. But certainly, if we extrapolate, we're heading towards a 20% increase, which, if it happens, will be the highest number of recorded deaths to date, unfortunately.
Okay, well,
And last year had seen a reduction, which is why it's disturbing to see it going back up again.
Yeah. But I mean, we always take a 3-year rolling average to try and iron out variations from year to year. But a 20% increase is very significant, we would think.
Yeah, it is, and obviously none of us here like to talk about statistics in a sense that each one obviously is a family devastated.
Absolutely.
Absolutely.
Somebody deeply hurt. In terms of, you mentioned Scotland, and they have seen a decline in the number of suicides. Isn't that right?
That's right, yes.
Yeah. Is there anything specific, and obviously we have our own set of challenges maybe specific to this country, but in a sense a lot of the issues would be the same
Indeed, yes.
across the UK, Ireland, and across the world for that matter. Is there anything that we could learn from what Scotland's doing that we could take on board here?
We've had regular contact with colleagues in Scotland, and even in the production of the new, a couple of years ago, the new Scottish suicide prevention strategy. We were involved with them in that. As I said earlier, what we do by and large mirrors what Scotland does. And Scotland has put down, on occasion, its decrease to its awareness raising programmes and to its serious focus on training and setting targets for training the number of NHS staff on suicide intervention and suicide awareness. And we're already training, and I think what we intend to do is continue that and up the game in training. But by and large, what we do is what Scotland do. One other area maybe that Scotland are more advanced than us is in terms of their statistics, their information around suicide and their information around the sort of contributory factors. They have a database called ScotSID that's very well developed. And again, I said we need to look at our databases and look how we can mine that information in a more effective way to pick up on trends and to find out sooner what's driving increases in suicide, what groups are affected, what areas are affected. So in terms, I would say, if you look at it in the round, I'd say an enhanced focus on training and better analysis and interrogation and reporting on the data around suicide, self-harm and suicide attempts.
I agree around what you're saying, enhanced training, and you'll know probably a lot of people, the likes of, including myself, have maybe been approached by somebody who is in distress, and it can be difficult to know what to do, and if we don't know ourselves, we can't expect everybody else to know as well, and it's about education. But do you think there should be more of an emphasis as well on private businesses, employers, maybe undertaking initiatives to try and reach large amounts of people? Because obviously it's not going to reach everybody, but the more people that we can reach and sort of educate about what should be done, because there's many families who are sitting around the table and somebody says, and there's a saying unfortunately within our constituency that I'm ready for the Foyle Bridge, for example. I don't like using that line, but that is what's used, and it's how you react to that. And that, what do you say? Do you just sort of dismiss it and say, well, hopefully they're going to be all right? Or do you say, no, you need help and this is where you need to go?
Absolutely. By and large, being in employment is good for mental health and well-being, but that's been in good employment. If you're in employment that is insecure employment, or if the demands exceed what, if there's huge demands on you and you're not able to control those demands, that's bad for your mental health and well-being. So there is a programme, and our colleagues in the Health and Safety Executive have developed materials and promote mental well-being at work, encouraging more workplaces to implement standards that have been developed to help protect mental health and well-being at work. And I mentioned that some businesses are involved. There's one organisation, Allstate NI, who have a team put together to promote suicide awareness and suicide intervention within their organisation, but have also come to the Suicide Strategy Implementation Body and have presented on their programme of delivering suicide awareness training to schools, for example. And that group have also offered to use their expertise in terms of IT to help develop apps around suicide prevention. So I would like to see more organisations follow that model. There's huge potential in that, I think. And if we can get organisations, particularly when organisations have specific expertise, such as IT, to come on board and develop interventions on that sort of platform, I think there's great potential in that, and I would dearly like to see more of it.
Sorry, just to contribute to that, the other thing is the mental health and well-being of the workforce itself, and there's quite a lot of work that has been done around that. But I think the bit you're going to is on how do you help somebody else. So there are a range of training programs, mental health first aid, safe talk, assist, depending on the level that is required. And I think workplace is one of the issues that we definitely are looking at. The other thing is that in terms of workplace health, the Public Health Agency is in the middle of procuring a service for workplace health, which is precisely all around health and well-being as a whole, but it will include mental health and well-being. So I think there will be increased opportunities as well as the opportunities that are currently being explored.
Yeah, well, Chair, I think that's positive to hear. And in terms of traditional ways of when people are in difficulty, where they would go, I think, in my opinion, that's changing. In that, traditionally people may have went to their minister or their priest or spoken to the police. Is there any? Are you seeing an increase in any services that are being done now online? I know within my own constituency there's counselling services starting to be done on a 24/7 online basis, where people can sit in their own homes. Sometimes they would rather be anonymous and speak to somebody online and say, look, I'm having a bit of difficulty, what do I do? Is there anything in the strategy that looks at that and looks at the sort of the digital?
We intend to include in section on new developments, particularly the use of IT and the internet in the new strategy, to look and explore where we can go there. There is evidence that men in particular like the anonymity of the internet in terms of seeking information about mental health and seeking information about suicide. So very often the internet gets a bad press in terms of sites that promote suicide or in terms of cyberbullying. But there's also a very positive side to the internet where people can go and get help. And even, I know that Samaritans have gone online and provide a lot of help online now. Childline provide a lot of help online, and they're seeing a big upsurge in terms of children contacting them online as opposed to telephones. So it's something that we have to build in to our future approaches. This is the way it's going to go, and we have to gear ourselves up to follow that.
Just one final thing, and I think Joanne touched on it as well, about the many good organisations and charities doing a lot of good work. The difficulty that I have is not with the fact that they're doing good work, they are, but there's a lot of them, and there's a lot of them doing the same things, fighting for the same funding, and us ourselves as elected representatives obviously try and support them all, but what can be done, what more could be done to try and prevent them from working in silos and maybe bringing people together? I know it's a difficult one to do because everybody has their own way of doing things, but I just think that it's something that we are going to have to look at and trying to provide the best service for those that need it.
I would agree with that, and I think that's what we try to do through the local Protect Life implementation groups that have the community groups from that area engaged in suicide prevention on them. So there's a sharing of information, a sharing of approaches, and that can only be good. But maybe, Mary, you'd like to talk about procurement services and
certainly,
and
but before I do that, maybe just, I think I recognise the problem, that in a sense, the strength that we have in the community voluntary sector is that there is so much and so much diversity, but then the problem is there is a conflict or potential conflict of interest. That said, I think there's an increasing maturity and there's also a willingness to work in coalition. For example, on those self-harm services that we mentioned, the new services, in 2 of the areas they are being provided by a consortium of maybe 5 or 6 different organisations at community level. So that's very encouraging, and that's only come about because they themselves have recognised the value and the added benefit they can bring to the service by that level of cooperation. But it is a real problem, and I think it does require a level of understanding and sophistication in a way from groups to be prepared to do that. In terms of the services more generally that we seek to procure, we will be procuring from the community and voluntary sector as part of the overall shape of the services. So we have already procured services for self-harm, as I've said, training, and as well as that, vulnerable groups, that is black minority ethnic groups, LGBT, and travellers, Irish travellers. The next phase of procurement will also look at bereavement services, the whole issue of community engagement and community empowerment, that facilitation type service, as well as some others, particularly young people. So that, again, our intention is to make that a procurement exercise to support the community and voluntary sector, but that will require people to come together. I think the evidence, if we look at the self-harm, is very encouraging, but it won't be a straightforward thing in all areas. And inevitably it does mean that some people will win, inverted commas, and others may not. But I think the more they work together, the more you will see a strength of that partnership coming forward, both in terms of the services they deliver and their ability, to deliver a stronger service.
Thanks. Thank you.
And Kieran?
Yeah, Chair, thank you very much. And thanks for your presentation and your briefing. Most of my questions have been answered, but it's just more a comment. And I would pay tribute to all of those organisations that are out there. I have a list on there. Despite the fact that they may be overlapping, they're doing excellent work, facilities, and helping you people to do your work. But I am disappointed. You give us good news and you give us bad news. The good news was that the lifeline was to be retained. Now that's good news. That's excellent news. The bad news was that you're expecting a 20% increase in the loss of life this year. That must be very
Potentially, yeah.
I know, yeah. Well, that must be very downheartening for not only yourselves but for the community. Despite all the good work that's going on, and you have invested $7 million per year, isn't that, for Lifeline? This is still, we're going to end up with potentially 20% more.
In this particular year, and I think we have said in the past, and it's been said by experts who've informed us on suicide prevention, that to really reduce suicide in the long term is a generational effort, and it won't be done anywhere in a number of 1, 2 or 3 years. It requires all that upstream intervention to build emotional resilience and to build coping skills, so when people who are vulnerable, who do experience adverse life events, are equipped to cope with those events in a way that doesn't involve self-harm or doesn't involve suicide. So this is a long-term project, a long-term programme, a long-term strategy, and we're not going to see any significant changes. I think that we had, since 2006, largely plateaued the increase that occurred from the early parts of the 2000s. It is disheartening, definitely, to see the significant increase in 2015, but we have to keep on at it, and we do have to focus more upstream. One of the positives I can come out with is that there's been so much research over the last number of years about the fundamental importance of the early years and of building mental health in the first 3 years of life and mental resilience. The PHA have responded to that by producing an infant mental health framework and interventions to improve the life experiences of infants, particularly those in maybe more challenging circumstances. But obviously it'll take a lot of years for that work to work through. There's work going on in the schools, much more so than in the past. So the recognition of the importance of building emotional resilience has gone in. That will, I believe, start to bear fruit in a number of years, but in the short term, I don't think we'll see any significant reductions in the short term.
That's disappointing. But there was one thing you did say to the committee, and that was, correct me if I'm wrong, that something that may contribute to suicide would be the insecurity and employment. You spoke about now, we are in a period of change where, in fact, in this House, not recently, you know what 0-hour contracts are?
Yes.
That could well be a contributor, because if you don't have a full week's work, you're not going to be able to pay the bills because you're living during the week, you have a family during the week. So 0 hours contract, if it's used properly, would be okay. But if it's not used properly, it can contribute to anxiety, possibly leading to suicide and loss of life. So, you know, there's something to be said for those in authority that's operating 0 hours contract to operate it properly and not to the disadvantage of the ordinary public.
As I said, employment is generally good for mental health and well-being and good for suicide prevention, but that employment has to be what is termed as good employment.
Yeah.
And that's where a person's mental health and well-being is protected employment, that they have control over their work, that they have some security of their work. Where employment isn't along those lines, where there's insecurity of employment, that certainly is a risk factor for
Well,
mental
that's
health.
very interesting indeed. Chair, thanks very much.
Thank you,
indeed.
Kieran. Rosie?
Margaret Carley, thanks very much for the presentation. See, in terms of the statistics that are in the report, do you gather statistics on basis of, like, for instance, geography, on different times of the year, and on social class? Because I'm thinking about in terms of directing resources, if you have more focused information, then it'll allow you to say, well, these are the groups of people who are most at risk. So, I mean, I live in Belfast, and there's a huge issue in Belfast about suicide and the increase of it, and even just in the past, you know, the weekend we had more deaths as a result of suicide, and as we're hearing, it's just set to rise and continue, and I'm wondering, is it really being tackled as effectively as it could?
I suppose I could answer that on two levels in terms of the data. NISRA maintain the data on suicides. That data is broken down by gender, by age group, by geographical area. So we do have that data. Now, by and large, that data, because it takes up to 18 months to 2 years to register a death of suicide, that data will always be a couple of years old, but it is still important. So it's from that data, for example, in the refresh of Protect Life, we changed the aim, and the aim we changed to was to reduce the differential in suicide between the most deprived areas and the Northern Ireland average. That was done deliberately to focus efforts at those areas, deprived areas, where there is greater incidence of suicide. So we have used the data from that perspective. We know from the data that men are 3 times more likely to die by suicide than women, and that's men has been in that 20 to 55-year-old age group. So therefore, that has been used to inform PHA services to direct them at meals. For example, you'll see the awareness raising, the PR campaigns tend to take place in the male environment. There's the one about the boxer, and the one about the fog, where it's the construction worker encouraging men to seek help, because men are much less likely to seek help for mental health issues than women. So that data does inform and does direct where services are delivered and how services are delivered. The key thing then about instant data is we don't have that, and that's a problem. Now, if there's been an increase in suicide in an area, in a specific area over a short period, that will show up hopefully through the sudden death notification system. That system is then used, the PSNI share that information with the trusts and with the PHA. PHA look at that, and that will help determine whether to activate a community response plan to go into that area, a cross-agency community response plan, to try and tackle the issue in that particular area. So we have an ability to respond quite quickly to emerging issues of suicide in an area. And I think we would like to do a lot more about that. So if you were to tell me, for example, there's been an increase in 2015, what has driven that increase? I couldn't tell you much more, actually, than, well, there's more young men in those figures than there has been over the previous years. So we know, oh, there's now a focus on young men in deprived areas. It had been that 20 to 55-year-old bracket. The research coming out about the legacy of the Troubles maintained that the suicide cohort would age, because the people affected by the Troubles through post-traumatic stress disorder, they would carry that, and suicidality would increase. But the latest figures don't show that. They tend to go against that. Now, figures for 3/4 of a year, you're not going to take as a trend, but that sort of came out of the blue at us. You know, we're now back to seeing in those first 3 quarters an increase in young men. But we've limited information to act in terms of what happens within a year. And that's, I think, where we need to improve our interrogation of the data and improve our correction systems.
And there's indications that the incidence of women are rising. Statistics that we heard recently in Belfast, there's an increase in the women taking their own lives. Is there anything to explain that, why that would be happening?
Well, I say we don't know, and a worrying trend is that part of the reason why fewer women die by suicide than men is that women have used less lethal means of self-harm, such as self-poisoning with drug overdose, where there's more chance of a recovery. Men have tended to use more lethal means, and we're finding in some of the latest suicides that more lethal means have been used, which is a worrying trend among females, I have to say.
This committee visited suicide groups last week in North Belfast, but it was a group of people who represented all of Belfast from all communities. And one of the things they were telling us was that the statistics actually underplay the real figures, because they don't include people who maybe end up dying later after a suicide. It's an attempted suicide, but death occurs maybe a week later, so that isn't included in the statistics. And
I think maybe they're referring there to the sudden death notification system, because those figures would be included in the statistics if it was death through self-injury or...
And then the other statistics would be more comprehensive, they would include everything.
The recorded statistics will always be more comprehensive, because the sudden death notification, that is filled in by the police officer at the scene. Okay. Now, bear in mind, when the police officer goes to a sudden death, their first priority that is to investigate whether there's been a crime. So this is an additional responsibility on them. They complete that form. Now, if there hasn't been a death, if a person has injured and has been brought to hospital, there won't be a sudden death notification form filled out. So I think maybe that's the data that the local group are referring to, as opposed to the general register data.
Just as a main point, these people are dealing with this issue day and daily, and you could feel it. You could feel it from them, the strain of being involved in that sort of work, and the desperation, because they feel that they're not supported, that the lack of the strategy, the need for a task force, and they just feel that, they obviously know the work has to continue and they want to do that, but they're actually firefighting. That's how they describe it. They're just firefighting. And so how can you respond to that sort of desperation coming from the people who are working, at the front line of this?
Yeah, and again, it relates back to the point I made, is we have to go upstream and address people's needs before they become suicidal, to reduce that volume of firefighting. Because by and large, that's what we're doing now. We're firefighting. People are coming into services in crisis and need to be stabilised. That has a huge impact on the people who deliver those services, both in the community and in the statutory sector. And there's research about the psychological impact on, for example, psychiatrists and GPs who lose patients to suicide. And that impact is very significant. And I have absolutely no doubt that the impact on community workers and volunteers addressing suicide is every bit as significant. And maybe I should have mentioned it earlier. Another thing that we're looking at in this strategy we haven't looked at in Protect Life to date is self-help and protection for the people who actually deliver suicide prevention services. And that was fed back about the need for the protection of the well-being who deliver those services. So we are including that in the strategy. And we have a template for that. I mentioned the Flourish initiative for the clergy. Part of that initiative is not just to equip the clergy to deal with suicide amongst parishioners, but also to keep themselves safe, because they are under pressure. They're dealing with very emotive issues as well. So we have a template in terms of delivering support to an important group of gatekeepers, but also within that support, an element of that support for keeping themselves well. And we can then look at that to see how we can apply that more broadly.
Would you agree that there is a need for more resources for talking therapies and more flexible approaches to that? Because, there's sometimes like a one-size-has-to-fit-all approach, and that can't be the case, and people get, say, a limited amount of counselling sessions, and then that's it. Do you not agree that there needs to be flexibility, given the very serious nature of this? And if this is a way that works for a lot of people who are in those circumstances, would you not agree that we need to look at more ways to resource that in communities where people, are living and where people are so desperate?
We engage with our colleagues in the Department of Mental Health Services, and those points are raised. And yes, ideally from a suicide prevention perspective, we would like to see better access to those services and flexible services, and that's where we deal, say, with our colleagues in mental health services who are responsible for
But given
policy around those
I mean,
services.
you're anticipating a 20% rise in numbers of suicides, so would you be looking at a 20% increase in resources to try and address that, what you're perceiving, something that is likely to happen?
Well, I can't speak for the resources side of it, but in terms of new resources that have already gone in, there are new developments. If we talk of Belfast, the mental health and wellbeing, the health and wellbeing hubs. Now, that's a new investment that the board has put into the trust, working in partnership with the community and voluntary sector. So those are new services. And one of the issues that is of concern, I think, to service providers is, yes, you're right, there needs to be a flexibility, but also there's a concern that there is duplication here, that a person may be in obvious need of support, but they're also a victim and survivor under another programme, and there is a need for us all to get better coordination of some of that work to help the individual and their family. So, absolutely agree with you about that. But the other point that I'd like to just come back to, if I may, is the issue of self-care and that point that you were making. In Belfast, we are currently piloting a method of support for some of those organisations for their own self-care, and that seems to me to be very important, and we're waiting to see how that goes, but we're definitely looking at rolling that out to other areas, because the people on the front line can feel it very, very hard at times, and I think it's on our responsibility, and all of us, we actually take that on board very seriously. Up until now, I think, as is often the case, it is goodwill that people rely on, because this isn't just about money. This is, commitment from those people. It's heart and soul, and you can't trade on heart and soul. You really have to resource it and support it. Mm-hmm. So, I think certainly from our point of view, we recognise that, and I think it's an important area.
Okay, just one final question. The Card Before You Leave initiative, has it been reviewed for effectiveness?
It was reviewed about, was that 18 months ago, I think?
Yeah, I think so. I think it was 2014, I believe.
And what was the result of it? Did it prove to have...
The review indicated that it was working reasonably well, and one of the issues, though, was the high number of do not attends, the high number of appointments that aren't attended. Some instances where people didn't get the card, some variation in the services, as mentioned. I think one of the trusts preferred actually to phone, get the phone number of the individual, and they found that to be more effective. So I think we have to allow for that degree of flexibility. If the trust is finding that they're getting more people to the appointments through that approach, I wouldn't, stick rigidly with a protocol and say they must get a card, because they were finding that some people were just throwing the card away.
You have to go with what works.
Yeah, so that was looked at. I think some of the learning was taken on board by the trusts that actually implement the scheme, and there'll be another review in the future.
Yeah, and I think that's something that we really just have to constantly look at, because if a person is referred into the service and they don't pitch up, well, how much follow-up and how often do you need to do that, and do we need to understand a bit more about why they're not pitching up? So it is an area for constant review, and particularly if we talk about the zero tolerance culture around primarily mental health services, but it would stretch into emergency services if people present. So that is about making sure that everybody is, captured in some way and managed through the system.
Yeah, I think it is important. It's very important to know why people don't attend. Because I think therein probably lies.
The National Confidential Inquiry into Suicide has made recommendations in terms of a greater focus on assertive outreach, where clients of mental health services miss appointments, that's not just passed on, that there's an effort made, particularly at those critical periods, for example, within 2 weeks of discharge from inpatient services. So those recommendations go to the trusts for the trusts to implement, and I know some of the trusts have been working at putting those procedures into place. Again, there's a cost, obviously, to assertive outreach, but we have a process in place through the confidential inquiry to make recommendations of that nature.
And just picking up on that very briefly, because I know Alex wants on as well. In terms of that meeting that the committee had last week with the sector and the services, and it was, I'm stressing the point, it was community sector right across the entire city of Belfast. And they're obviously focusing on the 55 deaths by suicide in Belfast last year alone, which is quite stark. I mean, I suppose, is there not a need for a particular focus, a particular task force, a particular interdepartmental, departmental approach? The groups, I have to say, were quite supportive of the work that had been done. There had been a particular interdepartmental focus, maybe that's not the right term, a number of years ago, which seems to have slipped back a bit. Is there not, when I'm listening to what you're both saying about almost moving upstream on the issue, but it's also about following the need and targeting the need. Is there not a specific case needed there?
This point was raised at the Ministerial Coordination Group meeting. The CMO responded that I'm not sure a ministerial task force, another layer, is necessary on this, because we have a number of groups out there.
Maybe not a ministerial task force.
I know that was the suggestion, was a ministerial task.
Maybe what I'm saying is some sort of task force that is coordinated in terms of all of the services, statutory services, something that the department would have a leadership role in, or would it be the Belfast Trust? But I'm working this on the basis of identifiable need on the back of those 55 deaths.
Yeah, the department and the PHA have discussed this, and I think what we're saying is there are a large number of groups involved. I was at a meeting earlier on in late 2015 about the increase in suicides in North Belfast, and also the increase in demand on mental health services. So there's obviously something happening there. We're seeing an increased demand on mental health services. People are now starting, people are responding to the need. They're saying, I have a need here in using services. Yes, we need to know what's driving that increased demand and what's driving increased suicide. There are a number of groups already involved in that. There were groups at that particular meeting, and there's a number of agencies involved. And I think maybe the approach is we need to look at what all the groups are doing, and you were suggesting, Mary, take a step back, see what the learning is out of the activation of community response plans. And maybe what you need, what is needed here is like a sort of a large-scale community response plan, if you know what I mean.
Who leads that, I suppose? Who drives that focus?
Well, Chair, if I may, just before we come in, I was sharing with Gerard what is simply a proposal, an idea. It would need to be discussed with people. But it was really, I suppose what I'm really thinking is, rather than another group, what we need to do is have a think tank, large-scale, reflective piece of work. At least that would be my suggestion. And it would obviously need to be taken to the chairs of the local suicide implementation groups. But you may know of a programme called Future Search, where you focus and you have your politicians, your policy makers, you have your academics, community, all these different stakeholders. And it did occur to me that if it's not Future Search, but a process like that, which would require in-depth reflection, scrutiny, a formal interrogation, but also recognising the learning, the things that are going well, and affirm the direction that is required for the future. Because what I'm worried about, if I'm absolutely frank, is that another group might actually take energy away from the people that are already there, already engaged, and focusing the efforts on the task. So,
No, I understand that, and I'm not suggesting replacement with another group. I'm just talking about
yeah,
in the absence of the strategy and in the increase in suicides in Belfast generally, there is a dire need there, in my view. And I understand the future search process because we went through it in Derry around the One Plan. But who leads that then? Who you know, how does that happen? How does that become? You know, who is it? The department? Is it the Belfast Trust? Who does that?
well,
Or what is the process? Is it PHA? Or?
Well, we hadn't got to that point, and I suppose what I was very mindful of is that there are people there, both from community and statutory services, who are already leading. They are leading the implementation of the Protect Life strategy. So I was being sensitive about the need to include their view. They may have a different perspective, but it struck me that an in-depth drill would be, helpful, and I think would confirm those bits, as I say, that everyone is comfortable with and feel that they're effective, and renew efforts in certain other areas.
Okay, well look, I don't want to bog it down in the specific piece, but I do think it's important to just clarify who then is responsible. Can you come back to us then?
Yes.
As that thinking is developed, because I think
Yes.
that's an important issue about target and the need that exists, and particularly
Yeah.
the stark
Yeah.
figures that we're facing. So thank you for that. Alex, sorry, you've been very patient.
I'll be quick, and thanks for your presentation. From about 2004, suicide rates seem to be going up, and it's obviously partly down to maybe better recording of people's deaths, and actually there was an increase in suicides, and we know that's down to different factors, such as deprivation and different things. And we've trundled along, and the trust's been going up and down and up and down, and there was a couple of years where it's going down and it went up again, and then last year it went down the furthest it's been down in about 5 years, and unfortunately we're going to see another spike this year, and everybody keeps scratching their heads and looking for factors and how we're going to deal with that. Is there any work being done on the influence of the internet, the likes of Facebook and Twitter and online bullying is what I'm referring to? You even get pages now where there's people advocating suicide, and I'm wondering, is the department looking at this as a possible factor that we're not being able to get a steady and decrease down? Maybe it's stupid because I'm not an expert, but it's, to me, the trend upwards seemed to come when social media started to come into force.
If you look internationally, I mean, Scotland have seen a steady decline. England has been reasonably steady. So I think you'd have to look internationally for that evidence. I think there's certainly evidence out there that cyberbullying certainly is a risk factor for suicide in the same way as physical bullying is. So I wouldn't doubt that it's a contributory factor, and certainly in terms of the internet sites that promote suicide, there's been action taken through the Child Internet Safety Forum to try and get those sites to close those down. So there's a process by which they're notified. But it's very, very difficult, as you'll appreciate, because a lot of those sites are hosted outside this jurisdiction and outside the UK. So it is difficult to close down because then they'll pop up somewhere else. So in the round, yes, certainly cyberbullying would be a contributory factor for suicide. There's no doubt about that. Sites that promote suicide make information about means of suicide much more readily available, and they are a worry. And there is action taken at UK level to try and address that. There would be no specific evidence that I know on a Northern Ireland basis about the contribution of those type of sites or cyberbullying to suicide. I think what we found, not that many, anecdotally, not that many cases actually have been down to either these honeypot sites or the cyberbullying sites, but that's only anecdotal.
What is maybe, of general concern is that the increased use of social media means that I I think for certainly young people, there is an increased concern about how they portray themselves, you know, that they are living through other people's eyes sometimes, and that in itself can add an additional kind of pressure. I'm not so perfect, you know, it's going on all the time, you know, the photographs of, you know, so just at a general level, I think as a society, we're feeling the impact of that kind of behaviour, which isn't always in our best mental health and well-being interest.
And Mary mentioned earlier about Annette Boutre from New Zealand, one of the world leading suicide prevention experts, and she mentioned before about legacy social media sites, so that when particularly a young person dies by suicide and their Facebook site, their social media site is still there, for example, other young people will engage with that site, there's a tendency, and leave messages on it. And the evidence is that is not a good thing, because what that does is that diminishes the understanding of the finality of death. So you will get text on sites like that so-and-so parties on in heaven, or the legend lives on, and that can be very damaging from the understanding of other young people, and that can contribute to what we call suicide contagion. So one of the fundamental aspects of the community response plans and the training for clergy and teachers is that parents are advised, parents who've unfortunately been bereaved by suicide, are advised to close down their child's social media site.
Okay, thank you.
Thank you. Just a final point for me, in terms of this experience in Scotland and the decrease there, is it because, well, has there been impact because they seem to have invested more in the CAMHS service, the children and adolescent mental health? They seem to have invested a bit in staff. The last figure I looked at, they had 869 staff, excluding trainees. You know, what numbers do we have here?
I would have to come back to you, Chair, on that one. Would have to.
But do
check
you
that from a
think,
mental health
from
service.
your experience and work in this field, has that impacted positively?
Well, I know that CAMHS have set up crisis intervention teams, and there's been a focus on intervention in terms of social and emotional crisis through CAMHS teams, and there are services available in each trust area. But in terms of the volume of services or access times for non-crisis intervention, I would have to get details on that
Can
for
you
you.
come back to us on those figures then?
Yeah, I'll have to get them from some colleagues, yeah.
Okay, can I thank you then both? I mean, obviously the issues have been well aired here today. Like, there is an issue about the delay in terms of the new strategy. There's obviously very genuine concern, I think much wider than this room, around the current 20% increase and what the rest of that year will bring. So we want to get the details around the development strategy and some of the other issues I raised directly with yourself. But thank you for your time today, and we'll certainly be keeping track of how this develops. Thank you.
Thank you for your interest.
Thank you.
Thank you. Members, moving on then to item 6, which is a statutory rule, the tobacco retailer fixed penalty amount regulations 2016, to page 26 of your meeting pack. We had considered and approved the rule at our meeting on the 27th of January 2016. There have been no changes to the policy content since the SL1 was submitted, and the examiner of statutory rules has no issues to raise. So are members content with the statutory rule? Therefore, the Committee for Health, Social Services and Public Safety has considered Statutory Rule 2016-5, the Tobacco Retailer Fixed Penalty Amount Regulations 2016, and recommends that it be affirmed by the Assembly. Item 7 is an SL1, the Recovery of Health Service Charges Amounts Regulations 2015. It's at page 35 of your meeting pack. Part 2 of the Health and Personal Social Services Act 2001 had introduced a scheme for the collection of the costs incurred by hospitals in treating casualties of road traffic accidents from compensation payments made to the casualties. the recovery of health service charges, Order 2006, just extended that recovery scheme from 29th of January 2007 to include all cases where an injured person receives personal injury compensation, and to embrace the cost of ambulance services and set the tariff of charges. So the proposed statutory rule will apply an inflationary uplift to current tariff levels. The rule is subject to negative resolution. So are members content that the department makes the statutory rule?
Agreed.
Okay, members, item 8 is an SL1, the Health and Social Care Disciplinary Procedures Regulations. Just refer you to pages 53 to 56 of your meeting pack for the relevant papers. The department again is proposing a statutory rule to provide for the investigation and determination by the Regional Health and Social Care Board as to whether chemists, dentists, medical practitioners and opticians providing health service treatment have failed to comply with their terms of service. And again, this rule is subject to negative resolution. So are members content that the department makes the statutory rule?
Agreed.
Item 9 is a legacy report for 2011 to 16, which is at page 58 of your meeting pack. Just to inform members that the report details the committee's achievements, its approach to its work and issues the incoming committee may wish to examine. It also includes appendices, details of committee membership throughout the mandate, some statistical information and a report on the work of the committee for the current session. If I could maybe just acknowledge the role of the committee clerks and staff in putting this document together. It's a substantial document and it's a useful tool, I think, for the committee to reflect on. There has been a significant impact and piece of work undertaken by the committee, so I think it is useful, and I want to just acknowledge the staff for doing that work. I would maybe suggest that in terms of issues that the committee may wish to examine, which is at page 67 of the report, that we would include the issue of suicide prevention and mental health as a suggested area of work going forward. So are members in agreement that we would include that?
Agreed.
Yep.
Yeah.
Okay.
Mr. Chair, just
Sure.
can I commend what you're saying about the report itself and the staff that prepared it, obviously. And of course, let's pat ourselves on the back, because there's a lot of good work that has been done. And as I said, I think in the House yesterday, it's not often acknowledged, but I think we should be proud that we have got through such a lot of work in the mandate.
Points well made. Thank you, Kieran, for that. Okay, item 10 then is the Forward Work Programme, which is page 78 of your meeting pack, and I'm just asking members to note at this point.
Agreed.
11 is Matters Arising. There are 4 items under Matters Arising at pages 80 to 84. Are members content to note?
Agreed.
And item 12 then is correspondence. There are 18 items of correspondence at pages 87 to 374 of your meeting pack. Just want to draw your attention to a number of them. Firstly, on page 343 is correspondence from Tackling Awareness of Mental Health Issues, who were asking to meet with the committee. Seeking agreement that we would write to the manager suggesting that they resubmit the request for a meeting when the new health committee is established, just procedurally following the elections. The next item I want to just refer to is 371, which is correspondence from an individual requesting an independent review of their case. Again, I'm seeking agreement that we would write to the individual advising him that the committee does not get involved in individual cases and provide him with the details of his constituency MLAs. Members in agreement with that?
That looks like a letter coming to me. You see the address. Anyway, yes, agreed. Chair, just
Sure.
before you go on, there's 1 or 2 there. If we
Yep.
could go back, I want to pass comment on. It's page 237. First of all, to express my disappointment that, despite the hard work carried out by Joanne Dobson on her transplantation bill, it has to be withdrawn. Just to acknowledge the work that but anybody that's putting forward a bill puts in. The other one is 324. 324. Yeah, that's the one about the autism.
Yep.
I wonder, now whilst we very much welcome the 2 million that was put in by by the Minister, we have had no response yet from the Education Minister. Would it be in order for the committee to write and ask what, if any, investment he's putting in? Because we do have the problem with education. We know that with the report that was just debated in the Assembly yesterday about parents being unable to get the proper education, you know, whenever the kids are diagnosed and statemented, etc. So there's a gap there that needs to be tackled. And if Simon Hamilton is prepared to put in 2 million, I would have thought that the Education Minister could have done, well, some similar investment.
Well, I mean,
To get us to
speak
where
for
we
the
want to
Department
be.
of Education. I do think there has been significant work undertaken. I know also as a member of the Education Committee around special education needs
Yeah.
and the duty to cooperate between the Department of Education and the Department of Health, and that's very much to be welcome. I would just say in terms of timing of this, we won't get an answer back before the recess. I'm pointing that out. I'm also pointing out that we have included the Autism Act as a specific piece of work for the committee and going forward. So I'm suggesting that we would maintain that and let the new committee agree if that's a piece of work going forward. So our members
Right, oh, that's fair
agreement to
enough.
do that,
Fair
because we won't have it in time.
Right. There's
Those
a
are
couple more.
Oh, sorry, go ahead, Kieran. Sorry.
There's a couple more, and that's page 342. Just to pass comment on the good work that's carried out by the kinship care people. Do you remember we had them up with the committee and the good work that they do in, you know, looking after youngsters. And finally, and probably very important, is P343. Has any, no, page
343, is it?
no, 345.
Okay.
Has any member read that report? Because that is an absolute shocking report. It's the unannounced care inspection of the Kingsway. Do you know the home that had been criticised for their non-compliance for elderly? And that was an unannounced care inspection. And whenever they went back, they found that 11 of the other recommendations in the earlier visit had not been carried out. So now, that's shocking. to
And
say
I
the
think,
least.
yeah, and I think we're very mindful of questioning the policy direction in and around this, the whole change in the culture of care report. And I think this is part of this. The committee had identified this as a key piece of work and going forward. Unfortunately, or maybe fortunately, the legislation took over in the last number of weeks, but it certainly should be a priority issue for, again, the new committee going forward.
Yeah, I'm
Absolutely.
just wondering, I think at the time, certainly I was under the impression that the Regulation and Quality Improvement Authority almost lacked teeth for to see improvements carried out, you know, and there's a perfect example where they had recommendations, 18 recommendations, and when they went back there was only 6 carried out, 11 remains, and one has to ask, you know, what's the point of having this organisation if we cannot see the recommendations carried out that they asked for?
No, absolutely. And I mean, when we had the RQIA, and recently that was a big topic of conversation directly with them, they were indicating that, I suppose, the remit that they have and the powers that they have are all kind of being explored now currently. And we asked them to come back to us as that is rolled out, because you're absolutely right. There is an issue about even the powers that they have, are they actually using them to the full extent? And what additional powers do they need? So what I would suggest again, Kieran, is that what I'm calling the culture of care needs to be on our list of potential issues to deal with going forward. So
Right.
if members are in agreement with that. Was there another one?
No, that's it. That's fine. Thank you very much.
Okay, thank you. Rosie, could you indicate?
Yes, no, Kieran raised the issue about the human transplantation bill, and I mean the committee did do a good bit of work on it, and I mean I thought it was regrettable that that Joanne withdrew it, because I mean there was a very considered piece of work by this committee, and we came to conclusions for very justifiable reasons that many of the clauses had to be removed because they weren't workable. So I think it was regrettable that Joanne didn't want to go ahead with that bill, but we've been able to have them included in the miscellaneous bills, so it's worked out okay in the end.
Okay, thank you for that. So are members content then to note the remaining items of correspondence?
Agreed.
And just 13 is any other business. Do members have any other business?
Yep, yes.
Rosie, yes.
There's two things. The first one is the Glen Mona facility. It's in my constituency, but it's closing down. Now, it's a facility that provides services to very vulnerable young people, and there's a dispute about the trust is, you know, there's negotiation going on, and the trust is at some level willing to go in there, but there's issues about pensions, and the staff are left not knowing what's going to happen. The people who use the services, the patients and the young people, are left not knowing if the service will continue. Now, I've written to the department, I've written to the minister, but I've no response yet. But I'm wondering, can the committee maybe write?
I would just be mindful again that it is a similar situation to what Kieran has raised. I think we do have to keep a focus on the overall policy around care facilities and daycare and all of that in terms of the culture of care piece of work. I'm suggesting that maybe, because we have the trust in next week, the Belfast Trust, on actually the Mother and Children unit, isn't that? I'm not going to declare for agreement on that. I'm suggesting that any members entitled to raise that. I think that'd probably be the more appropriate way to deal with it if people are okay with that.
Okay.
Was there
The other issue, and it is really just briefly, I've had a quick look at this report. It's called it's the trauma report, but we just got it, and just on a very, very quick look, it looks like Belfast Trust and locally in the north there have been failings. There's an issue around data collection, which was regrettable. There's also an issue that highlights the high incidence of falls for older people and higher incidence than normal of motorcyclists arriving in emergency departments with trauma. But I mean, I haven't been able to go into the detail, but the biggest one was the high priority waiting times in emergency departments in the RVH. It just seems to be above what's acceptable, and I'm wondering, I've just had a quick look, so I'm not speaking from having all of the information that's in the report, but just there's concern about it, and I just want to raise it.
Okay. No, that I think that's fine. And again, we have a specific piece next week around waiting times for cancer treatments, and what we can do is we can indicate that we will be wanting to raise those wider issues. I haven't seen the trauma report yet, but that we'll be looking to take that up directly with the trust. So, okay, thank you for that. Okay, members, then date, time and place of the next meeting, which is at, what do we see, the next committee meeting, which is the last scheduled meeting of the mandate, will be on Wednesday the 9th of March in the Senate chamber at 2 p.m.
All right, we don't have one following week.